Hello, my name is Ryan Stevens, and I'm an infectious diseases and antimicrobial stewardship pharmacist at the Mayo Clinic in Rochester, Minnesota. Today, I have the pleasure of reviewing the new utility of an old therapy in a discussion of the pertinent information surrounding convalescent plasma as it applies to the treatment of SARS-CoV-2. The mechanism of action with the utility of convalescent plasma in SARS-CoV-2 infection involves the adaptive or humoral immune system. In this system, the host develops pathogen-specific antibodies after exposure to an antigen. These antibodies then act to allow for neutralization and clearance of the infecting pathogen. This is predominantly accomplished via two mechanisms. First, active infection and survival. In this circumstance, an active infection confers immunity to future infection with the same pathogen for the duration by which the antibodies are present. This will come up several times throughout the course of this presentation, but seroconversion from a negative status to a positive antibody status in SARS-CoV-2 has been shown to take place somewhere between 8 and 21 days, depending on the specific antibodies. When we look at these antibodies, we see seroconversion to an antibody status happening at a median time of 11 days, with IgM and IgG specific seroconversions happening at median times of 12 and 14 days, respectively. The second mechanism by which adaptive immune system can be activated is vaccine, whereby an intentional exposure to an attenuated form of the pathogen or antigens of a pathogen stimulate the immune system to produce antibodies without the requirement for the host developing an acute infection. Vaccine development for SARS-CoV-2 is currently underway. However, in the interim, the study of convalescent plasma is gaining traction as a method by which to boost the adaptive immune system of an infected patient. In convalescent plasma therapy, the plasma of a patient who has previously been infected and survived, thereby having developed these adaptive antibodies as the activation of their adaptive immune system, is harvested by apheresis. This plasma from this patient can then be administered to another acutely ill patient, and the resulting effect is the horizontal transfer of passive immunity. The duration of this passive immunity will vary depending on the neutralizing titer threshold of the pathogen and the half-life of the transferred antibodies. However, in SARS-CoV-2, we're estimating that passive immunity may last for between weeks and months, thereby helping a patient to recover through the acute illness themselves and hopefully undergo seroconversion for future protection by activating their own adaptive immune system. As previously mentioned, seroconversion is estimated to take place between 8 and 21 days in patients with COVID-19. This study evaluated the serologic conversion profiles of 41 patients with COVID-19. For immunoglobulin detection, they used ELISA with both nucleocapsid and spike proteins. This test had a sensitivity and specificity of 90 and 95% respectively for IgG detection and 80 and 95% respectively for IgM detection. IgG seroconversion took place at a median of 11 days with a range of 8 to 16 days and peaked at 30 days. They also found that critically ill patients had a steeper IgG response curve. IgM seroconversion had a wider range and was less predictable than IgG. Specifically, patients' IgM seroconverted in 14 days with a range of 8 to 28 days. It then peaked at 18 days and then declined. This is also consistent with data regarding IgM seroconversion from patients with SARS-CoV-1. This study confirms that IgM will likely be of very little utility in tracking the disease and that IgG may be the best immunoglobulin target. The reason that I say that convalescent plasma is one of the newest, oldest therapies for COVID-19 is that it may just be coming to light for the treatment of SARS-CoV-2. However, the practice of convalescent plasma administration dates back as far as 1892 when it was used in the treatment of diphtheria. Over time, there have been a lot of diseases that convalescent plasma has been explored for, and notably, it's generally been the primary therapy for some infections prior to the antibiotic era. However, most recently, sort of since 2000, the year 2000, convalescent plasma has been explored for the treatment of 4 specific viral diseases: H1N1 influenza, Ebola, and 2 novel coronaviruses, SARS-CoV-1 and MERS-CoV. Through the use of convalescent plasma in Ebola in 2015, we didn't see this prove to be an effective therapy. However, the outcome in the treatment of influenza A, H1N1 in 2009, and more notably the other 2 coronaviruses mentioned above, SARS-CoV-1 and MERS-CoV, we have seen the demonstration of some positive outcomes. Though it's beyond the scope of this presentation to explore each one of these listed in this slide individually, I think it's important that we examine the activity of convalescent plasma in the treatment of coronaviruses specifically a little more closely, as it will help shape some of the discussion surrounding the use in SARS-CoV-2. First, I think it would be important that we examine the utility of convalescent plasma during the SARS-CoV-1 epidemic in 2003. During this epidemic, convalescent plasma was utilized in 80 patients in Hong Kong in the treatment of SARS. They administered between 1 and 3 units, which equates to 160 to 640 milliliters of convalescent plasma, and evaluated the primary outcome of discharge by day 22 post-convalescent plasma infusion. They found that of the 80 patients that were administered convalescent plasma, 33 or 41.3% were discharged by day 22 post-infusion. And when they evaluated the factors which appeared to contribute to a favorable outcome, they identified 2 key findings with regards to the patient improvement on therapy. First, they found that patients who received convalescent plasma within 14 days of symptom onset experienced a higher rate of favorable outcome. Specifically, 56% of patients who did experience a favorable outcome, which remember is discharged by day 22 post-infusion, had received therapy within 14 days of symptom onset. This is compared with a rate of administration prior to day 14 in only 15.6% of patients who experienced a poor outcome. The second key finding was that patients who were PCR positive but seronegative for SARS-CoV-1 antibodies at the time of convalescent plasma infusion seemed to be more likely to respond. This is demonstrated by the fact that 61% of patients in the good outcome group, as compared to 21% of patients in the poor outcome group, were found to be PCR positive but seronegative at the time of infusion. It is, however, important to note that the definition of seronegativity was not clearly defined in this study. Of course, these 2 findings are not totally independent. Patients early on in the course of infection are also more likely to be PCR positive and seronegative, thereby sort of linking these 2 factors and providing an explanation for each. And this could be important as we consider the use of convalescent plasma in SARS-CoV-2, where we know that there appears to be an acute viral phase of the illness, followed by a later immune activation phase. Additionally, we know that seroconversion in SARS-CoV-2 infected patients generally takes place between 8 and 21 days following symptom onset. So though much still remains unknown, it could be hypothesized that similar to SARS-CoV-1, specific early administration to seronegative patients may be a future direction for research and could potentially provide the greatest amount of benefit. Next, let's look at what is known from the MERS-CoV outbreak. This study outlines the use of convalescent plasma in 3 patients in respiratory failure due to MERS-CoV infection. All 3 of these patients were administered between 1 and 2 units of convalescent plasma and observed for early seroconversion following therapy. The convalescent plasma was obtained from 4 separate donors with varying titers of neutralizing antibodies, and though all patients recovered, only 1 of 3 experienced early seroconversion. This patient was also the only one to receive plasma from a donor who had a neutralizing antibody titer of greater than or equal to 1 to 80. This study, though small and limited, it yields an important point, which is that the donor antibody titer may play a key role in the level of success that we observe with convalescent plasma therapy. This will shape future discussions around convalescent plasma administration in SARS-CoV-2 later on in this presentation. When considering the data specific to SARS-CoV-2, there are no randomized clinical trials with current data available, although the studies are underway. What we have is 2 small, uncontrolled trials and 1 case series, which were all performed in China. First, by Duan et al., involved 10 patients who were 18 years or older, admitted with severe COVID-19, which was defined in this case as either a respiratory rate greater than or equal to 30, oxygen saturations less than 93% on room air, or a PaO2-FiO2 ratio of less than 300. Interestingly, this study excluded cases with serious general conditions such as severe organ dysfunction who were not suitable for convalescent plasma transfusion. The median time between symptom onset and hospital admission was 6 days, and the median time between symptom onset and convalescent plasma administration was 16.5 days. All patients in this study also received concomitant antiviral therapy, and 6 of 10 received methylprednisolone. The convalescent plasma treatment that was administered in this trial consisted of the administration of 200 mL of plasma from donors with neutralizing antibody titers of greater than 1 to 640. In the results, they describe an improvement in clinical symptoms and radiographic findings. They also show a tendency towards decreases in inflammatory markers. They did not observe any deaths in the study, and neutralizing antibodies were available for analyzing in 9 of 10 patients. Increases in titers were seen in 5 of 9 patients, and stable titers were seen in 4 of 9 patients. The second study outlined by Shen et al. Describes the utility of convalescent plasma in 5 adult patients admitted with severe COVID-19 that were critically ill. Their specific definition for critical illness and severe COVID-19 was progressive pneumonia despite antivirals, a PaO2, FiO2 ratio of less than 300, or mechanical ventilation at the time of study enrollment. The median time between symptom onset and hospital admission was 2 days, and the median time between symptom onset and convalescent plasma administration was 20 days. All patients in this study also received concomitant antiviral therapy, and all patients also received methylprednisolone. The convalescent plasma regimen that was used in this study consisted of the administration of 400 milliliters, or 2 200 milliliter infusions, of plasma from donors who were required to have an IgG titer of greater than 1 to 1,000 and a neutralizing antibody titer of greater than 1 to 40. The results that were observed were a normalization of body temperature within 3 days in 4 of 5 patients. Decreases in SOFA scores and increases in PaO2, FiO2 ratios were seen within 12 days. 3 of 5 patients were extubated within 2 weeks, and acute respiratory distress syndrome resolved within 12 days in 4 of 5 patients. They also noted that viral loads were decreased and became negative in all patients, and this was measured by a PCR cycle threshold of 40 for swabs collected from the nasopharynx. They also noted an increase in recipient neutralizing antibodies, and all patients were still alive at the time of publication, with 3 having been discharged and 2 currently in stable condition. The third paper we'll discuss was a series which was recently published in Chest. They reported the use of convalescent plasma in 4 adult patients ranging in age from 31 years to 73 years. The median time between symptom onset and hospital admission was 4 days, and the median time between symptom onset and administration of convalescent plasma therapy was 12.5 days. These patients were all critically ill at the time that convalescent plasma was administered, and they all received varying doses ranging from 200 mils as a single unit in one patient to 2,400 mils as 8 separate units over a 26-day period in another. The authors did not comment on the donor characteristics or the associated antibody titers from either the specimen or the donor. None of the patients died, and all 4 were reported to have experienced positive clinical and virologic outcomes, although these varied in each case. These 3 studies are encouraging. However, the lack of control groups in all should cause us to interpret them and apply them cautiously as we move forward exploring convalescent plasma. Recently, a study was published looking at the clinical efficacy of convalescent plasma for the treatment of COVID-19 in a multi-center design. This was performed in Iran and was prospective and observational in nature, where they compared convalescent plasma in conjunction with standard of care to standard of care. They infused a 500 milliliter plasma transfusion times 1, and that was followed by a second dose at the discretion of a physician if they didn't note any clinical improvement within 24 hours. Of important note, this transfusion had to be administered within 3 days of admission in order to be eligible for inclusion in the study. The plasma that was transfused was collected from donors between ages 18 and 60 that had to be asymptomatic for 14 days, but had been previously PCR positive and PCR negative at the time of donation. This plasma was also tested for IgG levels, or IgG positivity using ELISA. And they found that 98% of donors were positive for IgG and 75% of donors were positive for IgM. However, they didn't report the specific antibody titers. The inclusion criteria for the study included patients that were greater than age 18. They had to have the confirmed presence of COVID-19 and symptoms. They had to have an oxygen saturation of less than 93% on room air, and they had to have less than or equal to 7 days since illness onset. Patients were excluded if they were intubated, had severe liver or kidney disease, were found to be in septic shock. A physician had the opportunity to exclude them based on their discretion, and patients with improving clinical condition who were meeting discharge criteria were also not included in the study. So a couple important notes is first, again, just to reemphasize that these patients were within 7 days of symptom onset, and they also had to receive their plasma transfusion within 3 days of admission. What they really basically looked at was the use of convalescent plasma in what we would define as severe disease, but they excluded those patients who would have life-threatening disease. Here you can see the outcomes that were observed in this trial. As you can see, all-cause mortality was numerically lower in the plasma group as compared to the control group, but this did not reach statistical significance. The length of stay, as demonstrated by a mean plus minus standard deviation, the percentage of patients achieving a length of stay of less than or equal to 5 days, and the percentage of patients who did not require intubation all favored the convalescent plasma arm. Now, the authors do note that they did have some limitations to their study, including the lack of randomization. They specifically said it was difficult because patients had to be matched and typed for convalescent plasma, and if a match or type was not found within 3 days, then it inhibited their ability to be included in the active wing of this trial. Also, they note that concomitant use of antivirals was permitted, which seems to be a relatively common confounding factor in most COVID trials, including those with convalescent plasma therapy. Another new trial evaluated the efficacy of convalescent plasma therapy on specifically the time to clinical improvement in patients with both severe and life-threatening COVID-19. This was an open-label, multi-center, but randomized clinical trial that took place in 7 hospitals in Wuhan, China. The time course was between February 14th and April 1st of 2020, and they enrolled 103 adult patients with severe or life-threatening COVID-19 who were not enrolled in other active clinical trials. They had originally planned to enroll 200 patients, but given low enrollment numbers and declines in disease prevalence in the area, they decided to close the study early with 103 adult inpatient inclusions. This included 52 patients in the convalescent plasma group and 51 control group patients. I've listed the exclusion criteria here, and I'm not going to read all of them for you, but I will note that it's a relatively lengthy list. And so it is definitely worth paying attention to specifically things like severe sepsis and also other contraindications that were determined by the patient's physician at the time of enrollment or evaluation for enrollment. Donors for the convalescent plasma used in this study had to be between 18 and 55 years of age. They had to have had lab-confirmed COVID-19 and recovery, which was defined as being asymptomatic for at least 14 days. And they had to have measured IgG antibody titers specific to SARS-CoV-2 of greater than or equal to 1 to 640. The dosing that was used was 4 to 13 milliliters per kilogram of recipient body weight, and the primary outcome that was evaluated was time to clinical improvement within a 28-day period. Their secondary outcomes included 28-day mortality, discharge by day 28, and conversion of the PCR from positive to negative at the time interval of 24, 48, or 72 hours post-transfusion. Specifically, they found that with regards to clinical improvement, there was no difference between the two groups, although it did appear to potentially favor numerically the convalescent plasma group. Even more when we dive into the outcomes of this study, we find that there was a better effect in patients with severe COVID-19 versus life-threatening COVID-19. And this was demonstrated by both the percentage who experienced improvement by day 28 and the time to improvement. So if we look at the severe disease patients, the primary outcome of clinical improvement by day 28 was observed in 91.3% of patients receiving convalescent plasma versus 68.2% of patients not receiving convalescent plasma, for a hazard ratio of 2.15 that was found to be statistically significant. Conversely, if we look at the life-threatening disease population, 20.7% of patients were asymptomatic by day 28 versus in the convalescent plasma group versus 24.1% of patients in the control group, which did not reach statistical significance. Also, they found that in the severe group, they tended to have faster time to clinical improvement by 4.94 days. 28-day mortality specifically demonstrated no difference. Discharge by day 28 demonstrated no significant, but rates of negative conversion of the nasopharyngeal PCR was higher in the convalescent plasma group at all time points, including 24, 48, and 72 hours. Notably, only 2 patients of the 52 that received convalescent plasma therapy experienced adverse events in this study. One was a rash and chills that resolved with steroids, and the other was within the life-threatening COVID group, experienced shortness of breath, cyanosis, and dyspnea within 6 hours of transfusion, and this resolved with the administration of dexamethasone. Also, all in all, the study didn't find statistically significant improvement in many of the outcomes that they looked at, but was likely underpowered to do so given early trial termination. And there were several numerical favorings for the convalescent plasma group, specifically in those with severe disease. And I think that's an important finding that also sort of mirrors the finding of the Iranian study that we previously evaluated. And so moving forward, perhaps it's been theorized based on this study that there may be a greater benefit to using convalescent plasma in patients with severe disease as compared to those with life-threatening disease. In the May version of this webinar, I highlighted a Cochrane meta-analysis that looked at the use of convalescent plasma in SARS-CoV-2. This is an update to that meta-analysis, which now includes 20 studies, 5,443 patients. However, they still note that the overall risk of bias is high due to study design, the type of participants that were included in these studies, and concurrent or previous antiviral therapies. They looked at 3 outcomes with regards to efficacy, including mortality, symptomatic improvement, and time to death. They're very uncertain whether convalescent plasma has an impact on any of these outcomes, again, primarily owing to very small studies and that are both randomized and or controlled in nature. With regards to safety, they included 14 studies. This includes one study that contains 5,000 patients, which is an evaluation of the National Expanded Access Program that we'll go into in more discussion later on in this presentation. However, they're also uncertain whether convalescent plasma is associated with serious adverse events, and this owes to a few things as well. Very few of the studies that report on adverse events actually grade the severity of the adverse event, but rather just classify the number of serious adverse events that were observed. Specifically, the study that we'll look at a little bit later that included 5,000 patients only looked at the risk of serious adverse events within 4 hours of transfusion. And so our ability to fully understand the scope of adverse events, though most likely would be accompanied right next to the transfusion, is somewhat limited in that nature. The group also noted that there were 98 ongoing studies of convalescent plasma or hyperimmune immunoglobulin, 50 of which were randomized in nature. So obviously there's much more to come on this topic. A major question that continues to be asked as we evaluate the use of convalescent plasma in the scope of this pandemic is who can donate convalescent plasma and how? Currently, convalescent plasma donations are still being processed through the American Red Cross and other participating FDA-registered blood banks. These blood banks don't have to obtain any sort of supplemental licensing or obtain their own IND in order to collect and manufacture investigational use COVID-19 convalescent plasma. They just have to follow their standard operating procedures and regulations with regards to plasma collection and restrict collection to those donors who meet the eligibility criteria. Patients are eligible to donate convalescent plasma. First, must be eligible to donate other blood or blood products by current standards. Additionally, they have to have experienced both proven disease as measured by a positive nasopharyngeal PCR or positive serologic test, and recovery, which is defined as a period of 14 days since last symptoms. Note this is different as it used to state 28 days from last symptoms with no negative test or 14 days with a negative test. Currently, and most recently, patients only have to have experienced 14 days since their last symptoms and proven disease, and a negative COVID PCR is no longer required for donation qualification. Donors also should be HLA negative, and the FDA indicates that optimally donors would have neutralizing antibody titers of greater than 1 to 80, or in other words, at least 1 to 160, though they do state that antibody titers of 1 to 80 may be used if alternatives are not available. It's important to note that only a few centers in the United States are capable of doing specifically neutralizing antibody titers, and if neutralizing antibody titers can't be obtained in advance, then centers should store a retention sample of the plasma for testing neutralizing antibody. There is some work being done to correlate IgG titers to neutralizing antibody titers, yet that continues to be ongoing work, and it's important to note that several of the commercially available antibody tests only test qualitatively rather than quantitatively, making it difficult to correlate IgG levels specific to antibody levels. So then, who is eligible for receipt of convalescent plasma therapy? There are three mechanisms by which a patient may obtain access to convalescent plasma. The first is through clinical trials, and the protocols for these trials vary, but include sort of three different tiers. The first is a protocol for asymptomatic patients, where it is essentially being used as post-exposure prophylaxis in adults greater than or equal to 18 years of age who are at high risk for severe illness as defined by the CDC and who have experienced a high-risk exposure in the previous 120 hours and have not yet developed symptoms. The protocol for mild to moderate disease involves adult patients greater than or equal to 18 years of age who are able to be enrolled within 3 to 7 days of symptom onset. This call for early administration makes sense given what we know about SARS-CoV-2 seroconversion and the time of 8 to 21 days, and also the SARS-CoV-1 data showing seronegativity and early administration yielding the greatest benefit. The severe protocol includes adults who are greater than or equal to 18 years of age with COVID-19 requiring mechanical ventilation. The second and third methods by which a patient could gain access to convalescent plasma is through the expanded access and single patient emergency IND. For expanded access program, facility enrollment is required, as is an IRB submission and protocol. For more information on this, you can visit the FDA website, where there's also a link to the National Expanded Access Protocol. Patients eligible for expanded access program must have lab-confirmed COVID-19 and severe or immediately life-threatening disease. Severe disease is defined as dyspnea, respiratory rate greater than 30, O2 saturations of less than or equal to 93% on room air, a PaO2-FiO2 ratio of less than 300, or the demonstration of lung infiltrates involving greater than 50% of the lungs within the previous 24 hours. Life-threatening disease is defined as respiratory failure, septic shock, and multiple organ dysfunction or failure. The single patient emergency IND access program is for those who are unable to gain access to convalescent plasma via clinical trial or the expanded access program. It has similar enrollment criteria similar to the expanded access program with regards to severity of illness. And enrollment requires the FDA Form 3926 be filled out and sent in non-emergent cases. This typically results in a decision within 4 to 8 hours. However, in emergent cases where a decision is needed faster than that, a physician can call a toll-free line and get expedited approval, where the turnaround time is typically less than 4 hours. However, it's important to note that if the provider does call, they still must fill out an FDA Form 3926 and send it in within 15 working days of approval. Finally, it's important to note that the product is not specifically being supplied by the FDA, and again, it is being manufactured and distributed by FDA-registered blood banks. The optimal dosing regimen of convalescent plasma in the treatment of SARS-CoV-2 is currently unknown. A couple of factors need to be considered when we talk about dosing of convalescent plasma. That includes the volume infused, typically referred to in units, where 1 unit is roughly 200 to 250 milliliters of plasma, and neutralizing antibody titers. Both of these factors will likely impact the seroconversion of the host and subsequently the success of treatment. It's important to remember that the volumes of plasma infused and titers in the available studies has varied greatly. It's also important to note that though antibody testing is becoming more widely available, only a few centers in the United States are capable of doing neutralizing antibody titers at this point. And given the limited ability for testing of neutralizing antibody titers, work is currently underway to correlate IgG titers by ELISA with neutralizing antibody titers. However, this work is still ongoing. All this considered, the design of regimens has been based on experience with convalescent plasma in SARS-CoV-1, where 5 milliliters per kilogram was given with a neutralizing antibody titer of greater than or equal to 1 to 160. Regimens are also designed by taking into consideration the anticipated recipient neutralizing antibody titer of 0 and a typical human plasma volume. Using these two elements, a regimen can be determined in order to target a specific threshold for neutralizing antibody titers in the recipient post-infusion. However, appropriate dosing regimens are sort of a moving target at this point in time, and recommendations will likely change as our ability to screen donor titers and understanding of the disease and neutralizing antibody titer thresholds evolve. Current study protocols are administering 1 unit of plasma for patients in the prophylaxis protocol and 1 to 2 units of plasma for patients in treatment studies, where the second unit of plasma may be administered at the discretion of the treating physician. This has also continued to evolve over time, with some protocols now indicating that patients greater than 90 kilograms may be candidates for 2 units, and that patients at risk for transfusion-associated circulatory overload should be considered for administration of 1 unit only. The current infusion rate for these products is being recommended at 500 milliliters per hour in most protocols. With regards to the safety of convalescent plasma administration, most concerns hinge around the various infection risks which are possible. The first is antibody-dependent infection enhancement. This phenomenon has been described with other viruses, most notably dengue, where subneutralizing concentrations of circulating antibodies may suppress the innate antiviral system of the host. This would allow for increased intracellular growth and replication of the virus and a paradoxical worsening of the illness. This remains largely a theoretical concern with SARS-CoV-2, and the concerns stem from some in vitro models where they used monoclonal antibodies, which is compared to the polyclonal antibodies that would be found in convalescent plasma. It would seem unlikely, given the current experience with SARS-CoV-2 to date and other coronaviruses, that this would occur, but it should be considered. Secondly, concern has been raised for transmission and transfusion of active SARS-CoV-2 to an acutely ill patient. Theoretically, this concern could happen as a donor who had not completely recovered from the disease could transmit circulating virus to the recipient. But this would seem unlikely in that very low percentages, somewhere around 1% of symptomatic patients have been found to have circulating virus in the blood. Nonetheless, it's prudent to carefully screen donors to be sure that they are not actively infected. This is evident in the donor criteria requiring 28 days since complete symptom resolution or 14 days since symptom resolution with a negative PCR. Thirdly, there's concern regarding the transmission of SARS-CoV-2 to healthcare personnel. Again, if donation criteria were not strictly adhered to, it would remain possible that healthcare workers involved in the collection and/or processing of samples could be exposed to the virus. So strict adherence to donation guidelines will help to minimize this risk. Lastly, concern exists regarding the transmission of other infectious pathogens, given that this is a blood product. However, the risk of these pathogen transmissions, such as human immunodeficiency virus or hepatitis C or hepatitis B, is not really presumed to be higher than that observed with the administration of other plasma products in pre-pandemic times. And given current screening of donors, this is unlikely to be of significant concern. Adverse reactions that could happen with the administration of convalescent plasma are similar to those that would be observed with the administration of other blood products, predominantly fresh frozen plasma or FFP. Severe and life-threatening reactions are possible, including transfusion-related acute lung injury, which has been reported in the use of convalescent plasma administration in other viral illnesses, such as Ebola. This occurs relatively rarely at a rate of less than 1 case out of every 5,000 units of plasma that's administered. However, it could be disastrous in the case of a patient already in respiratory failure with COVID-19. So careful screening of donor specimens for HLA antibodies will help to mitigate this risk. Additionally, transfusion-associated circulatory overload may also occur, and though this has generally been associated with the administration of large volume of blood products. Current study protocols are only recommending 1 to 2 units of convalescent plasma, but that considered, it should be noted that the risk factors for transfusion-associated circulatory overload include advanced age and cardiac and renal disease, which also mirrors those who are at risk of severe COVID-19. Anaphylactic and allergic reactions are also possible, as with any blood product administration. At the first sign of any of these severe or life-threatening reactions, as manifested by signs of anaphylaxis, respiratory compromise, hypotension, significant changes in heart rate, or even at the judgment of the administering provider, current protocols recommend terminating the infusion. Non-life-threatening reactions may also include febrile, non-hemolytic, or urticarial transfusion reactions. These may be lessened by pretreatment with acetaminophen or diphenhydramine, and if they are observed, current protocols recommend slowing the rate of infusion. Recently, data has begun to emerge from the National Expanded Access Program for convalescent plasma in the treatment of COVID-19. The data released is from April 3rd to May 11th of 2020, during which 14,288 patients were enrolled in the program, with 8,932 receiving transfusions. The data details the safety of convalescent plasma from the first 5,000 patients. With regards to serious adverse events within 4 hours, there were 36 events observed from the 5,000 infusions. This included 15 deaths, 21 non-deaths, which were made up of 7 transfusion-associated circulatory overload cases, 11 transfusion-associated lung injury cases, and 3 severe allergic transfusion reactions, all making up only a fraction of 1% of total transfusions. Mortality at 7 days occurred in 602 patients, or 14.9%, as estimated using a Kaplan-Meier product limit estimator. Further separated by ICU and non-ICU, you can see mortality rates of 16.7% in ICU-admitted patients and 11.2% in non-ICU admitted patients. Given that this was only a review of the safety of convalescent plasma and not specifically designed to assess efficacy, the authors caution readers on over-applying this data with regards to efficacy in the treatment of COVID-19. There are not a significant number of drug-drug interactions to be observed with convalescent plasma therapy. However, given that convalescent plasma is essentially FFP from a patient previously infected with SARS-CoV-2, it does have the potential to interact with the INR of patients anticoagulated with vitamin K antagonists. The dose of FFP given for warfarin reversal is generally related to the pre-admission INR, but a typical dose of 10 to 15 mils per kilogram is given for reversal of supratherapeutic INRs. In a 75 kilogram patient, this would equate to roughly 3 to 5 units. This is notably higher than the doses that are being used in the current convalescent plasma protocols. However, as pharmacists, we should note that the administration of convalescent plasma may impact the INR in patients receiving warfarin. The INR should be monitored in this scenario with appropriate bridging with alternative anticoagulants if reductions in INR are observed. Though these products will be provided by blood banks, it's important to note that there are specific labeling requirements as defined by the FDA. The labeling must include a statement including caution, new drug limited by federal or United States law to investigational use. The label should also be uniform, and the FDA recommends use of the International Society of Blood Transfusion format, which is outlined in the United States industry consensus standard for the uniform labeling of blood and blood components. The expiration date of convalescent plasma should be similar to other plasma products. It should be frozen within 8 hours of collection and stored at negative 18 degrees Celsius or colder, and it expires 1 year from the date of collection. Here I've detailed for you a few resources if you're looking for more information on convalescent plasma use in COVID-19. Specifically, the FDA release, American Red Cross, ccpp19.org, and uscovidplasma.org all have great resources for those who may be candidates for donation of convalescent plasma. In summary, the mechanism of action for convalescent plasma in the treatment of SARS-CoV-2 has to do with the transfusion and transfer of passive immunity. Data is limited to evidence from other coronaviruses and small studies and case series, and donors should have confirmed infection with recovery prior to donation and should accomplish their donation at an FDA-registered blood bank. Recipients may be enrolled by one of 3 mechanisms: clinical trials, an expanded access program, or a single patient emergency IND. The optimal dosing of convalescent plasma is largely unknown at this time, although current protocols are recommending the administration of 1 to 2 units or 200 to 500 milliliters of convalescent plasma, optimally with a neutralizing antibody titer of greater than 1 to 80. With regards to safety and adverse effects, infection risk, and other risks typical to blood product administration are concerned, and theoretical lowering of the INR for patients on warfarin may be observed with the administration of convalescent plasma therapy. I hope this has been a helpful review of the utility of convalescent plasma in the treatment of COVID-19. More information is sure to be known in the near future as we continue to carefully consider the utility of this therapy in the treatment of the active disease of SARS-CoV-2. Thank you.